Appreciate the Go Ute sentiment. Hope there's no ducks in the crowd. Had an enjoyable Saturday. So appreciate the opportunity to speak here today. Very excited that our neighbors, Intelligent Insights, have this program. We think it's fantastic to be able to bring together thought leaders, innovators, technology specialists, now architects. I think we're the first two architects that have been involved in this process. But for us, it's important because it's taking healthcare to the next level. And we think that's critical from what we do, which is kind of the very beginning of a hospital or a clinic, all the way through, obviously, the end users, which are all of you, and making sure that we understand the process from start to finish. So very excited to be here. Again, Todd Medd, Healthcare Practice Leader for JLG Architects. I'm also the Fargo Market Leader for JLG. And JLG Architects is a North Dakota-based firm. We've become a regional firm over the last few years. And really our focus is design for life. And that's critical to us, and for me in particular as a healthcare design leader, making sure that what we do creates buildings that are healing, promote wellness, cutting edge, reduce the cost for our owners, not only today, but into the future, and make sure that overall we're creating buildings that are fantastic for our clients, and even more importantly in healthcare for our patients. So I know you guys got the opportunity, at least some of you, to visit Sanford Clinic in Moorhead yesterday. How many were able to go out to that visit? Okay, a majority. This project's pretty near and dear to my heart. I was the project manager for this project, working with Sanford Health. And in talking about process and talking about integration, talking about technology, Sanford is what we feel is a poster child for that integration. And so I'm going to use that as a little bit of a case study regarding ambulatory care settings and process, and the importance of how we work with you guys in that process. So Sanford has had some pretty big goals for this project, and I get excited when clients walk in with huge goals, great vision, wonderful ideas. We wanted to reinvent the patient experience with a new prototypical clinical care model. And we wanted to do it, as all of our projects are, on a tight budget and a fast-track schedule. So we were excited to have that opportunity to really start digging into this project about 4 years ago when we started with Sanford. So healthcare, architects, engineering, we look at metrics. It's so critical for us to understand how the building performs. So I'm going to start kind of at the end of the process, looking at what we created with Sanford Moorhead, and kind of work backward into how we created it. So with Sanford, they told us, we want to integrate a lot of technology, we want to integrate a lot of innovation, we want to change the clinical care model. So the first thing we started looking at is self-rooming. We talked a little bit about that earlier this morning regarding how self-rooming is a big part of this model. So if anybody went up to the innovation lab at lunch, you got to see a little bit of this. We have some chairs set out that demonstrate this. But a typical a typical clinic has 6.2 chairs per physician in the facility. For me as an architect, the best way that I can manage my client's budget is reduce square footage. If I can reduce square footage, I can reduce cost. For me, this is fantastic because I just went from essentially taking waiting rooms that are sometimes underutilized and cut that out of the project completely. What it means for the patient, when they walk in the door, they walk directly to their room. That is great because they've gone from 5 minutes to 2 minutes to meeting their nurse. The question became very early in the process, using RTLS, using wayfinding, would people actually utilize this self-rooming mentality? We found, using Intelligent Insights software, that 76% of mothers coming in for well baby check were actually using it. Which we thought was fantastic. And if you think about it, it makes a lot of sense. You're coming in with a 1-month-old baby, 2-month-old baby, getting that baby checked. You don't want to sit in an exam room where people are coughing and sneezing and touching the toys and touching the books, and it's just not a great environment for infection control. So the ability for us to bring people directly into the exam room is huge. Once you got in the exam room, we were challenged with decreasing the size of it. The typical Sanford Enterprise exam room was 125 square feet. Our goal was to get down to 110 square feet. We did that through innovative use of furnishings, pass-through cabinetry, going from a typical swing door to a barn door, which takes a little bit of getting used to, but we found that by doing that, we're able to decrease the square footage. And again, as the architect, making sure we're on budget, that was critical for us. What this means, again, for the patient is the length of time with your physician is increased, the time you're in the clinic is decreased. And this one is a little bit more contentious. So when we started the project, we decided that we had to take and make this as efficient as possible, make this as integrated as possible, make this a collaborative space for delivering care. So probably the most difficulty we had was convincing physicians that we were taking away their office. No place to hang your fish on the wall, no place to have the grandkids on your desk, but really taking the physician out of the office and putting them directly next to the exam room, directly next to the nurse, next to the health coach, driving integration, driving process. Working with Jeff Haas at Sanford, I know he's told me this numerous times. For him, it was difficult because he had to try and convince the physicians that this was important. Today, talking to physicians at Moorhead Clinic, they've thought it's been fantastic. And so for all of us that were part of this and going through those tough meetings where we're talking about how we're going to redesign the clinical care model, once you go back into the clinic and hear from the people using it and saying that it works, we find that to be fantastic. Again, the flow stations, I'll show pictures of that in a little bit here, and if you toured it, you got to see those firsthand. Those really helped increase the interaction. Those brought the physicians out of their offices, next to the nurses, next to the health coaches, and really created that integration that we wanted to capture. And on average, nurses at Sanford Moorhead Clinic are walking 71 miles per month less, which is truly fantastic. And it goes down to the finishes. We used an intuitive finish implemented wayfinding system that helped people coming to the clinic understand how to get from point A to point B. The last thing we want is somebody coming for a visit to get lost, to get confused, and to not understand where they're going, especially with a self-rooming model. So this comes back to the importance of process. And you know, as we all know in healthcare, that the only constant is change. With the ACA, with the change in reimbursement occurring, with a dramatic increase in demand for use, not only with an aging population, but also a lot more people utilizing care with the ACA. We're also seeing a change in the way care is delivered. A shift towards retail care models, a shift towards larger players being involved in the process. We're seeing that Walmart is wanting to get into healthcare, and Target and CVS using kind of mobile exam rooms as part of their retail model. So obviously change is critical, becoming flexible, understanding how to adapt, creating our spaces that react to that need for flexibility. This is also fascinating. What we do as architects, in that small phase that Noah did a great job of explaining, where we're designing the buildings and the administrators purchasing the land and actually building a project, is only 15% of the total cost of any healthcare expenditure, capital outlay for a clinic, for a hospital, for all healthcare buildings. 85% is the cost to run it, to staff it, to maintain it, to operate it. So as architects, we need to think beyond just today. We need to think beyond just what the cost of that material is and look at the whole picture of what it's going to cost everybody here to run that facility for now and into the future. So the question becomes, how do we optimize the design process while elevating the clinical care model, allowing the client to reach the greatest value? Ironically, when I started laying out how we went through this process in preparation for this, I realized there was really 10 key factors. So I'm channeling my inner David Letterman here and doing my top 10 list of key tools that we use for our process. And if this works out, I'm sure Ioana will have me back next year doing stupid human tricks. So let's give it a shot. So number 10, define your why. Now this sounds simple. This sounds like the most commonplace thing to think of when you're starting a project. It's amazing how many people don't do this. So we define our highest goals, we define our why, and we create a list. And then we break down that list. First meeting, we walk out of there and we've got our top 2 or 3 or 4 goals for the project. As the leader of the project, the first thing I talk about in every meeting, budget. Second thing I talk about, schedule. Third thing I talk about is goals. Every decision we have to make goes directly back to those goals If it doesn't relate to those goals, we cut it out and move on. The amazing part about this is if we've got a strong why for a project, we can, if there's any CFOs or CEOs out here, I'm sorry, but we can change CEOs in the middle of the project. We can change CFOs in the middle of the project. We can change a facility manager on the side of the owner, and it keeps coming back to the goals. We've had projects where we've had that happen. A president leaves, a new president comes in. The project doesn't change. We just keep moving forward. Number 9, use case studies in existing facilities tours. I think they say that the smart man learns from his own mistakes. The wise man learns from somebody else's mistakes. And not only mistakes, but looking at successes. Traveling around the country and looking at some of the opportunities, looking at projects that Array has done, looking at projects that some of our other partners have done, projects that we've done in the past, and understanding what works, what doesn't work. It creates a focus, and it creates an understanding of what we want the next project to be. Again, Noah did a great job of explaining lean process. And on the side of the owner, we think it's critical to have an understanding of lean process to optimize the layout of your project. At Sanford Moorhead Clinic, one thing you see here is the pass-through cabinetry. That was something that was critical. We realized how much time nurses were spending restocking. Well, a nurse isn't hired to restock. We wanted to take that away from the nurse, away from the physician, so that the tools that they needed on a daily basis were right there at their fingertips, and that was done from the backside. So if somebody comes in and has a special case and they need a certain cart, that can come in using RTLS. We're going to know that they're in the room. We can bring the carts in from the back. There's seals around the doors. There's no concern about HIPAA. Everything is sealed within the exam room, and the nurse and the physician have the tools that they need. The other thing you see here is the flow stations. Talked about that a little bit earlier. Using and working with our clients and whomever they're using for furniture is critical. The flow station allowed the physician to come out of the office. It allows the nurse to be involved with the physician. It allows other people to be involved in the process. It creates collaboration. And you can see how it reduces the number of steps that we have to take from point A to point B, which increases flow, increases throughput, and really increases the amount of time that the physician and the nurse spend in front of the patient. So apparently Noah had almost the exact same image. Architects like pointing at things on the wall, apparently. So this is where we have all the fun in the world, is when we get to lay out a plan, we get to lay out trace paper, and we get to really start working through with our owners exactly what the project is going to be, what it needs to be. And I can't stress to you enough the critical importance of having buy-in at this phase from everybody in the process: physicians, nurses, supply chain, environmental services, our engineers, structural, mechanical, electrical engineers, all coming together and creating a very defined process of engagement and a defined process of buy-in. This is where we take the functional models, the functional program that is created by us in the early phases, and then start creating those adjacencies and start creating the flow through the space. So number 6, communication. We create buildings. The number one tool we use to create those buildings is communication. With Sanford Moorhead Clinic, there was a lot of shared risk in that. We were taking a clinical model that had been working for many, many, many years, and we broke that down and completely changed it around. So in order to make that work, we needed everybody on the same page, in the same room, heading in the same direction. With Sanford's leadership, with the team that we assembled, it was an amazing process that we went through. And the wonderful thing about it is, I think Robert De Niro in Meet the Parents talks about the circle of trust. We created that circle of trust within this group, and it was so critical in order for us to share that risk, but also share the rewards. And I think we could all agree that Sanford Moorhead has been a great reward for all of us. We've created a lot of great opportunities, great things, changes in process that we're going to keep looking at improving, but making sure that we have everybody in the same room heading in the same direction. Number 5, physical mock-ups of critical spaces. For a very small amount of money, Noah noted this as well, we can create all the spaces that we're going to replicate 50 times in a project. If you're creating 50 exam rooms, let's figure out how that exam room works before we build it in the building. This is early on. We created the flow station, kind of the offstage area. Then we created the exam room. We actually brought in old furniture that they had laying around. We put a sink on the wall. We put the sharps on the wall. We put all of the cabinetry in place as if it were to be built. A very small amount of money. But what it does is it creates the ability for the clinicians to come in here and really work through the space, tell us what works, what doesn't work. We adjust it, we tweak it, we bring them back in, we work through it so that when we actually bring it out to the space, we know it's going to work. We also brought the contractors through and said, here's what our expectations are, here's how it's going to look. With Sanford Moorhead, we pretty much replicated, no matter what the room was, with some different variations, whether it's peds or women's. We did change furniture around a little bit, but for the most part, we wanted to create that flexibility so that anybody could use any of the spaces as the change in clinical care model happens, or as needs arise. We can move different modalities into different parts of the clinic. Obviously, fit and finish was a little bit of an issue, but we got that figured out before we built it. So we just want to make it economical, we want to make it quick, and we want to make sure that it works and it functions. This is the exciting one. Number 4 is virtual design coordination. We use Revit, as does Array, in all of our projects. Building information modeling, creating buildings in 3D, is more than just for the way we think in 3 dimensions. What it also does is allows us to work with our team very early in the process on coordination. This is not Sanford, this is actually Sanford Fargo Medical Center that we're teaming with HKS Architects and Mortensen Engineering on with Sanford. But I thought these pictures were so awesome. This is all the coordination that we've done with Mortensen on the layout above the ceiling. We all know how much effort goes into coordinating everything above the ceiling. Let's get it right in the model so that when we build it, we can do prefabrication. We can make sure everything's in the right spots. We can make sure that the structure is coordinated with the building. And you just see what happens. I mean, we hide this with ceilings, but this is really what happens above the ceiling. Med gases, fire protection, duct work. We've got all the IT up there. And really making sure that we understand that before we start building it. Digital visualization, number 3. This is where we get to use the model for something a little bit more fun than coordinating ductwork, and really helping people gain buy-in and understanding what the building's going to look like. So this is the original rendering for the exterior of Sanford, and here's the actual built product. And then the interior, and then the actual built product. And we did this for a lot of the spaces, the exam rooms, the back of house areas. We wanted everybody to understand and gain that buy-in early in the process so that they understood what the goals were. Number 2, post-occupancy evaluation, lessons learned. This is one that easily we could stick our head in the sand and say we're not going to go back and we're not going to talk to the people that are inside of our building. But we really want to learn that information. We want to understand what worked, what didn't work, and then keep tweaking that process. Unlike washing your hair, it's not lather, rinse, repeat. We want to make sure that every project we do, which is a prototype, even if you're taking something you've already done a similar project for, every building is a prototype. We want to make sure that we understand what worked, what didn't work. We found some things that didn't work at Sanford Moorhead, and we're going to change those on the next project that we do. And the number 1 tool for this entire process, and I can't understate this one enough, and I think that working with Sanford, working with our entire team on this project, we realize the critical nature of this is owner leadership, buy-in, and project passion. I know that the team led by Jeff Haas from Sanford was fantastic. They said, here are our goals, let's make it happen. And moving forward, we all had that understanding of what those goals were, and we executed and created a wonderful project. And no matter what the project is, having that understanding that the owner has your back and you've got the owner's back, and that your entire team is working together is so critical. As we move towards ever-changing healthcare horizons, moving towards more complex process, moving towards a change in how care happens, we need to have buy-in that this is the best process, and that we can continue to change it, whether it's implementation of technology or whether it's the use of the fantastic tools that we have in our toolkit. So with that, that's our top 10 list, and I appreciate it. Thank you.